Hello and welcome to Kaweah Health's Community Engagement webinar. Today is Thursday, February 23rd, 2023. My name is Deborah Volleson and I'm the Director of Community Engagement here at Kaweah Health. This is actually our first webinar of 2023. Maria and I were talking and our last one was in December, right before the holidays. So we're really excited to get to sit down with Gary Herbst, our CEO. And today we're going to cover several topics. We're going to talk about the state of emergency that's coming to an end in California and how it's going to affect our hospital. We're going to talk about the staffing update here at Kaweah and also review the January financials. I'm also going to ask Gary to give us a peek into what he has been doing at the legislature level here in the state of California. You're all aware of the letter that he sent to the governor of California, Governor Newsom, but now he's doing a lot more work and talking to a lot more people. So we're hoping he's going to give us a little in to what he's been doing. So welcome, Gary.
Yes, thank you, Deborah, and welcome to our Community Advisory Committee members, our Ambassador Group members. Welcome to our community. So great to be back. I thought for certain you were going to say today is 2/23/23.
I didn't think about it,
yeah,
but that's
fascinating
awesome.
with the numbers. Don't usually see that very often, but yeah, great to be back.
You're a numbers guy. That's why you saw that.
Yeah, you can take the boy out of the country, but you can't take the country out of the boy, something like that they say. So, yeah, but I'm looking forward to answering all your questions and any other questions that might come in. Always welcome. Chats throughout. Do we have a means to receive questions?
We do. You can chat in. Those of you who text me, feel free to text, and I'll also monitor my emails.
Yeah, so definitely encourage you. Any questions that come to mind during this broadcast, or if you want clarification on anything I talk about, feel free to chime those in. So,
okay, Gary. So let's go ahead and start. Let's talk about the census here at Kaweah. We're still pretty busy.
Yeah, so every morning, or actually twice a day, I get an email, 7 o'clock in the morning, and then in the evening what the census is throughout the entire organization. I think we all tend to focus on the census in the acute medical center downtown here in Visalia. So at 7 a.m. this morning, our adult occupancy rate was at 90.4%. Still busy, but less than the more than 100% occupancy, where we literally had sometimes 50 to 60 patients holding in the emergency department that had been admitted, but there wasn't a bed available. So at 90%, still very busy, but with a little bit more wiggle room. How that breaks down, we had 11 of our 41 ICU beds that were open and available for admission, 19 of our 54 intermediate critical care units, 3 West and 5 Tower, but only 9 of our 237 medical surgical beds. So when you think of 2 South, 2 North, 3 South, 3 North, so forth, those are our medical surgical units, and most all the beds were full there. We did have 7 patients this morning that were in the emergency department that a determination had been made that they needed to be admitted, but again, they were waiting for one of those medical surgical beds to open up upstairs.
So can I ask you a question?
Yeah.
So we're at 90% occupancy rate, and of course those don't include the 11 ICU, 19 ICCU, but you said we had 9 available beds in med-surg. Then why would we be holding
the 7?
Yeah.
Yeah, because they might not be clean yet. Those beds might not have been turned over yet. It could be the staffing at 7 o'clock. We weren't able to accommodate all those patients to come up. But this is just, a snapshot, right at 7 o'clock in the morning. So it very well could be that by now, those 7 patients did in fact move upstairs into those 9 beds. So that's always kind of the limitation of just giving, where we are at this current moment, because throughout today, we'll probably discharge close to 40 to 50 patients. But then many more will be coming into the emergency department, and we'll probably, even though we've discharged 40 or 50 patients today, we'll probably be at 90% occupancy tomorrow, which means that we had 40 to 50 patients come into the ED during the day and got admitted. So every day is a fresh day. It is a dance, yeah.
Okay, so how many COVID patients do we currently have? Yeah,
so COVID is definitely out there, but the variant that I don't even know the letters and the numbers now that we're tracking. It's probably in the X's and the B's and so forth, but it's definitely out there, definitely prevalent, definitely still spreading, but we're not seeing, you know, certainly the acuity of illness. We're not seeing as much hospitalization as we did during the peaks of the pandemic. As of 7 o'clock this morning, we had 22 COVID positive patients that were in the acute medical center. They were all adults. Yesterday we had a pediatric patient with COVID, but he or she was discharged, and so we didn't have any pediatric COVID patients in the hospital this morning. One of those 22 adult patients is in the ICU and is on a ventilator. You know, terrible to hear that, although we're seeing that most all of our patients, you know, are making a full recovery and are discharged, and so that probably is very likely for this patient in the ICU. But on the fortunate side, we see very few of our COVID patients now going into ICU or ICCU, which again is so much different than it was in the winter of 2020 and 2021, where our critical care beds were literally at max capacity with COVID patients.
So in December and January, we had no pediatric beds available. Up and down the state, pediatric wards were full. What are you seeing now?
Yeah, as I guess I haven't met with this group in a while, but definitely we're coming out of the heavy respiratory, at least the most intense period of the traditional respiratory season. This year we saw quite a bit of flu, mostly influenza A. We saw a huge amount of RSV in December and January, while we were also seeing COVID patients. So kind of the trifecta, as we refer to it in the healthcare industry. But RSV is continuing to decline. RSV doesn't just occur in children. It can be in very young infants, 6 months, and we typically think of it as a virus that affects children, but it also affects the very elderly as well, particularly those that might be immunocompromised. Throughout the respiratory season, we've probably had just as many children or just as many adults admitted with RSV as children. But it is definitely on the decline. Over this last week, we only had 10 confirmed cases of RSV, and we currently, let me see here. Yes, so 10 reported last week, and only 5 of those 10 had to be admitted. So we have a 12-bed pediatric unit here that is staffed by pediatricians that are part of the Valley Children's Hospital medical staff. Both our neonatal intensive care unit, which is staffed by Valley Children's Hospital's neonatologists, and then our pediatric hospitalist. So in that 12-bed unit, today we only have 4 pediatric patients that are in that unit. So definitely things have gotten a whole lot better. You're right, we were running pretty much at full occupancy. We're having great difficulty even transferring patients to Valley Children's. I know we were having to send some of our pediatric patients to San Jose and down to Los Angeles. And you, I think, were on the liaison call the other day, and Valley Children's indicated that they now have capacity and aren't turning away any requested transfers. So that's good.
Yeah. So you mentioned that flu season came early this year, because sometimes, I think somebody said it sometimes doesn't hit until like January or February. So are we also seeing the decline in the flu?
Yeah, we actually start what we call our flu surveillance period right around the 1st of November. We all tried to get our flu shots, our flu vaccines, generally in late September, early October, because we start seeing the presence of the flu generally in November. Sometimes it can be delayed. This year was a little bit more intense in terms of, we did see thousands of confirmed cases of the flu. We had a lot of admissions that were related to the flu, and we suspect that it's not that we're letting down our guard, but we're gathering more. We're not, necessarily exercising all of the hand washing habits that we so religiously did back in the height of the pandemic. So just probably more exposure. The flu can go all the way into April quite commonly. And what has been fascinating is during this pandemic, we actually were seeing quite a few flu cases in the summer, which is very rare. But it does appear, here we're almost at the end of February, that all three, COVID, flu, RSV, all starting to kind of temper down.
I hope this crazy weather doesn't kick it back up.
Yeah.
Now that we're freezing outside today. Okay, so on February 28th, the COVID state of emergency for California is coming to an end. So how does that affect Kaweah Health?
Yeah, so the governor announced, was it back in December maybe, that he would be declaring the state of emergency as being over on February 28th. I don't know why that date was picked. He has his crystal ball that determined that on February 28th, the state of California would no longer, I don't think he's thinking that there's no longer COVID present, but certainly I think a lot of it's impacted by the availability and the effectiveness of vaccines, the availability of antiviral treatments like Paxlovid or Paxlovid, however you want to pronounce it, things that we certainly didn't have early on in the pandemic. So even though COVID is still present, he's made a decision that he'll end that formal state of emergency on February 28th. They're separate from the state emergency. There's a federal emergency, and May 11th is the date that the federal emergency. That's kind of odd. Why not May 1st? Why not May 31st? May 11th. That's interesting. And there's very different repercussions associated with the state emergency and the federal emergency. So on February 28th, or I guess technically on March 1st, probably the biggest impact to us as hospitals is that under the executive order, hospitals were permitted to essentially use any space in the hospital to provide patient care. So recognizing that hospitals were overwhelmed and that they were running well above 100% occupancy, we could turn a classroom, we could turn a conference room or a meeting room into a patient care area. And even though it was not licensed for patient care, there were exceptions that were given. Also, the licensing requirements, particularly of, say, certified nursing assistants that normally could not provide any patient care until they had actually been licensed officially by the state, we were able to, they were able to begin providing care after they had graduated, completed a certified program, but they didn't actually have to have their state license yet to provide patient care. So that was another exception. There were a lot of exceptions to the nurse staffing ratios that we were exempt from them while we were under the executive order. So mostly things like that. I would say, having negative pressure rooms for COVID patients, and just many times some of the facility code regulations that we were given some latitude, some flexibility, because we had to turn units almost overnight into negative pressure units. That, you know, a hospital might normally have a few negative pressure rooms in case a patient had tuberculosis or some communicable virus or disease, but to turn an entire 34-bed unit into a negative pressure unit, and we actually had to do that to multiple units. We got to bypass all of the normal regulatory process that we'd have to go through. So now we're going to have to go through that. If we want to keep those rooms at negative pressure, we're now going to have to go through that normal process that we didn't have to while we were under an executive order.
So if that affects our nurse staffing ratios, and we're going to talk about staffing a little bit later, but is that going to affect our staffing even further?
I think what it's going to mean is there is going to be much more stricter enforcement. I'm the first to confess, you know, that oftentimes because of the severe nursing shortage that we've been experiencing, and not just us, across the entire nation, many hospitals, most hospitals have had to operate out of ratio. And the state has, I think, you know, kind of backed off its very normal, strict enforcement of that. And hospitals will still be permitted to apply for a hospital-specific, what they call a program flex. So, you know, even during very intense flu seasons, that if we can demonstrate to the California Department of Public Health that we are experiencing this, you know, huge surge, then we can get a special exemption from a particular ratio for a specific period of time. So the hospitals up in Fresno, with the closure of Madera Community Hospital, you may have been reading that, like, Community Regional Medical Center, St. Agnes, they're still experiencing occupancy rates well above 100%. They're using, you know, putting patients in hallways and still using unlicensed space. I think Community Regional yesterday was holding 75 patients, admitted patients in the ED. So kind of a much more intense experience there. So it's likely that they will be applying for hospital-specific continuing exemptions from those nursing ratios. But it has caused us, just the nursing shortage in general, we are beginning now to implement what's called team-based nursing, where you know, typically, at least with respect to the California nursing ratios, they are very strict. A patient in the ICU or a nurse in the ICU cannot have more than 2 patients. Oftentimes they only have 1 patient, but that's because of the severity of illness or the acuity of that patient requires one-on-one care. In the ICCU, it's 1 nurse to 3 patients. On a telemetry unit like 4 Tower, it's 1 nurse to 4 patients, and then on a general medical surgical unit, it's 1 nurse to 5 patients. So those are the California ratios, and if you don't staff to those ratios, then you get fined $30,000 a day by the state. And California has the strictest nursing ratios of any state in the nation. Many other states have nursing ratios, but California is the only one that requires a hospital to be in compliance 100% of the time. So you can never be out of compliance, even for meal breaks or rest periods, things of that nature. So under team-based care, which is becoming more and more common, LVNs also count towards those nursing ratios. So maybe that medical surgical unit that has a normal 1-to-5 ratio, well, you can increase that 1-to-6, 1-to-7, 1-to-8, meaning 1 RN to 8 patients, but then maybe you need to have 1 or 2 LVNs that's a part of that team. And so it's not just the RN taking care of that patient, but also the LVNs participating in that patient's care. They each have a very defined scope of practice, so only RNs can do assessments, only RNs can do certain things around medications and treatments, where LVNs don't quite have the same scope, but they definitely can be very impactful to supporting that nurse. So that's what we're rolling out right now. It's a major change in the care model for us, but it's really become a reality. The Community Regional Medical Center, I think St. Agnes have been using team-based care for some period of time, but you're just going to see it become really the norm across the country because we don't see the RN shortage abating anytime soon.
That's crazy. And when I'm on those liaison calls, you can almost hear the panic in their voices because, they're way over capacity. They've got admitted patients holding. They're all nervous about this state of emergency ending and how it's going to affect them. So it's kind of sad listening to that.
Right.
Yeah.
Yeah, and it's going to be interesting to see what happens next week.
Right.
Given the condition, given the severe nursing shortage, given just the financial dire situation that California hospitals are all experiencing right now, will the governor change his mind?
Yeah.
When we get to that, midnight on February 28th, will it get extended? The federal government has extended the federal emergency 2 times now. So it possibly could get extended beyond May 11th. Rescinding the federal emergency probably will be much more impactful to hospitals than the state emergency. There's so many funding enhancements, financial enhancements that have come with the federal declaration of emergency. Coverage of Medicaid patients has been significantly enhanced. There's great fear that a large portion of the Medi-Cal population or Medicaid population in other states, that they will lose that coverage. There also was enhanced funding for Medicaid or Medi-Cal for us. That goes away. There's something called sequestration that went into effect many years ago where the federal government pretty much has cuts all federal entitlement funding by 2%. So for years we've lived with a 2% cut to our Medicare funding, but during the federal emergency that was suspended, and so we were not being subject to that 2% cut. That now goes back into effect. So all those things will serve to reduce federal funding to hospitals who are already suffering mightily. And so there's a lot of advocacy going on at the federal level asking the federal government to keep those provisions of the federal emergency intact.
Okay, so what about masking? Our employees are asking.
The most common asked question next to parking, huh?
Yes.
Yes. So with respect to healthcare, we have not received any indication from the state what's going to happen. And so all of our employees are very, very anxious. We have in non-patient care buildings, like the one we're in right now, where no patient care is provided, we no longer have to wear masks. But in any building in which health care is provided, then our employees must wear a mask. So my office is in the acute medical center, and even though no patient care is provided in my office or that area, I still have to wear a mask because I'm in a building in which patient care is provided. And so everybody is hoping that at a minimum, people like me who are not actually on the patient care floor or in the direct area where patient care is being provided, that we would no longer have to wear a mask. But certainly if we went up onto the floor or rounding on our staff, then we would have to wear a mask in that situation. So I think that's what a lot of healthcare workers are looking for, but so far no indication if that's going to happen.
Okay.
And we pretty much, it's the California Department of Public Health, but it's also the Office of Statewide Office of Healthcare, OSHA. Should know what OSHA stands for. I know it's Office of Safety.
I rely on you to know.
I
all
know.
of this.
I just refer to them as OSHA. So, yeah. But we take our direction from CDPH and OSHA.
Yeah. So what about vaccine requirements?
So again, there's been no indication from the state, and remember that there are mandated vaccination requirements for healthcare workers. So those of us at Kaweah, we back in September of 2020.
December was when we...
Well, December 2020 is when, oh yeah, okay, thank you. December of 2020 is when vaccinations first became available, when vaccines first became available. Hospitals were then given till September 30th of 2021 to vaccinate all healthcare workers. So not just direct care providers, but all healthcare workers had to be vaccinated with either the 2-shot Pfizer, the 2-shot Moderna, or the 1-shot Johnson & Johnson. But there was an exception, an exemption, if you had a medical contraindication, and you had to have a signed physician note supporting that, or you had a religious exemption or reason for not taking the vaccine. And if you did that, then you had to wear a mask and you had to be subject to weekly surveillance testing. So if you were a healthcare or a direct patient care worker and you chose not to be vaccinated, then you had to have a COVID test twice a week. If you were unvaccinated but not a direct patient care provider, then you had to be tested every week. So that surveillance testing for unvaccinated employees has now been rescinded, so we don't have to do that weekly COVID testing anymore. But healthcare workers are still subject to that vaccination requirement. So any new employee that we hire has to get vaccinated or prove that they've been vaccinated or apply for that exemption. So that could change on March 1st, but we've heard no word that it will be.
Okay, so when will the hospital totally open up? Like it used to back in 2019.
The good old days?
The good old days.
Yeah. Well, I think it's when CDPH tells us that we can. And again, you know, we're a bit frustrated that we're only a week away from, you know, rescinding the executive order, and there's more questions than answers.
No answers, yeah.
So I think, again, it's going to be the CDC, CDPH, perhaps OSHA, that gives the all clear sign and says you must go, I mean, you can go back now to your pre-pandemic visitation policies. But that said, it also, I think, will continue to be based on just, you know, the occupancy that we're experiencing, the intensity that we're experiencing, the volumes that we're seeing in the emergency department, the number of patients, you know, in the waiting room, or visitors in the waiting room. So I don't know if you're going to see entirely just going back to the no limitation, no, you know, 10 visitors in a patient's room, or 5 go back into the ED, into the exam room with the patient, or 5, the whole family sits in the waiting room with the patient. I don't know if we'll go back to that, frankly. And I think hospitals are just, you know, now just more busy than ever. I mean, even though these respiratory viruses are starting to subside, I mean, you know, we're running almost 100%, you know, year round. And so that may cause us to restrict a bit. Certainly not the restrictions that we've all had to live with.
Okay, so let's talk about staffing. How many open positions do we currently have?
Yeah, so as of Tuesday, I think it was, we have 487 open positions. That's a lot, but certainly quite a bit less than the all-time high of 800 that we had during the point of the pandemic. Of those 487 open positions, 184 of them are registered nurses, 59 are LVNs, and 16 are certified nursing assistants.
So in direct correlation to that, travelers. We were down a little bit, but now we're up.
Yeah, I think our high water mark was at 240. We then went all the way down to 75. It's a beautiful graph to look at. But because of, I think, a little bit higher volumes and still continuing to experience staffing shortages, I mean, at 487 positions, we'd actually dropped down to about 300. So it's kind of, gone back up. Unfortunately, healthcare workers are burned out. They've been at this for almost 3 years now. And a lot of them have just, decided to leave the profession and go do something else. A change of mindset, just a different experience. And I appreciate that. I mean, I certainly understand that. This pandemic has been incredibly taxing on our physical, emotional, mental, spiritual, mindset. So, but we bounced back to, we have 105 today. We hope that'll begin coming back down. Our goal is to get to 40. And even
is that normal? Was that like pre-pandemic?
No, that's even a little higher than pre-pandemic.
Okay.
I still remember, you've heard me talk about that the most we ever spent on travelers in a single year in my 30-year history here was $8 million. Normally, we might spend $1 million, maybe $2 million tops in an entire year, in an entire 12-month period. And so that might mean 20 travelers. So if we got down to 40, that would still be significantly more, but we're still, even when the pandemic's completely over, assuming, I don't think COVID will ever disappear. It's now going to become a seasonal virus or maybe a year-round virus that just exists. But at some point, the pendulum of nursing resources will swing, and hopefully we get back to a lower level of traveler nurses, but probably will never get back to what it was pre-pandemic.
But even though we're up a little bit, the rates we're paying are lower.
Yes,
so.
Yeah, and that has been hugely impactful. At the height of the pandemic, when we were, using 240 traveler nurses, we were commonly paying more than $200 an hour. Sometimes approaching $300 if it was a critical care nurse or an ED nurse. And sadly, never let a crisis go to waste is what the contract staffing agencies thought, as we'd be paying them $200 plus an hour, but they might turn around and pay the nurse maybe $80 out an hour, $90, which was still quite a bit higher than the $50 that a nurse would likely earn as an employed nurse. And so very, tempting, very attractive, appealing. And so we certainly know why a lot of nurses left their employment at their hospitals and went and became traveler nurses. Unfortunately, as the rates come down, we're pretty much averaging right now between $125 and $130 an hour. So a significant drop. The agencies themselves have taken a little less profit, but most of it has come on a lower wage for that nurse. So a lot of them have decided it's just not enough of a difference between what they were getting paid as an employed nurse versus what they're getting as a contract nurse. And so we're seeing a lot of those traveler nurses coming back to work.
Okay, good. I'm going to throw in a chat right here because I know the last two questions I don't want to have to interrupt you with. But so the chat has come in. When will the next set of interns arrive? How many will be coming, and do we know their specialties? Will there be continued need for help from the community in housing these interns? So I'll answer the last part of that question. Yes, we are going to offer community hosting to our residents who are coming in. And I believe they start working on the match in March.
Yes.
Okay. All right. So yes, and if you are interested in being a community host for a resident, I'm handling the community side of that this year. And so just reach out to me and I'll get you the application, and then I'll put you in our pool. And when they reach out to the interns, they are going to use that as really a, what's the word I'm looking for, as a selling point for someone coming here, because they won't have to worry about housing and they won't have to stress about that.
Yeah.
And so, so yes, and so reach out to me and I'll get you that application. So Gary, when do they arrive? And do you know the specialties?
Sure.
Or will we know that?
Yeah.
Okay.
Yeah. So we are going, we've been interviewing medical school students, you know, over many months now. I think the interview season actually started in the fall. And these medical school students, they interview with multiple different institutions over the course of that interview period, and then they will rank their favorites, you know, from 1 to maybe 10, and then we will also rank our favorite students from, say, 1 to 10, and then magically in the month of March, the match occurs, and that's when the students and the institutions learn where they matched, and we learn who did we match with. So we have 6 different residency programs: family medicine, emergency medicine, general surgery, anesthesiology, psychiatry, and a 1-year program called transitional year. So it's kind of like a general introduction to medicine for a resident who wants to go on to become a radiologist or a dermatologist or to go into some subspecialty. So it's just a 1-year program. So we currently have 130 residents across those 6 residency programs. We also just recently launched a child and adolescent psychiatry fellowship. So not a residency, but these are residents that then go into a fellowship training. So after that match occurs, we will have about, we'll graduate close to 50 residents, and that graduation will occur in June of this year. And then generally maybe 1 week later, so at roughly the last week in June, those 45 to 50 brand new interns will arrive at Kaweah. In fact, every year I get to welcome them on their very first day of their residency program. It's always at 7 a.m. on Monday morning, but their bright, shiny faces, they're all decked out in suits, and they look unbelievably professional. And but we, Dr. Winston and I, start the orientation process for them. So they kind of get acclimated that last week in June, and then their academic year officially starts on July 1. So
yeah, and last year we had a party too. We had a resident community welcome party, so I'm sure we'll do that again this year.
Yeah, well, and great, and I agree, to differentiate ourselves from those other programs that they're looking at. Helping arrange housing for them is huge, because a lot of institutions don't do that. The resident, you're pretty much on your own. So obviously, as we're interviewing, we're promoting that as a unique benefit or service that we offer.
Yeah. So thank you for the question, and reach out to me. That would be great. All right, Gary. So January financials, are we trending in the right direction?
Yes, we are. We still incurred about a $2.3 million operating loss in the month of January, which, if I looked back over my 31 years now here, to me that would be devastating to have a $2.3 million loss, because that's not our historical experience. I could probably count on maybe one hand, maybe I'd need two hands over those 31 years, the number of months that we actually had an operating loss. Unfortunately, over the course of the pandemic, it's become commonplace. In fact, it's hard to look at any month since March of 2020 that we actually had a profit. I think we did maybe in July of 21. But every month has been very, very challenging. We similarly had about a $2.5 million loss in December. But contrast that with how we started this fiscal year. So this fiscal year we're in right now started July 1, 2022. We lost $8 million in that first month. On the heels of that, we lost another $8 million in August. And then we lost $12 million in September. That's the single largest loss in our history other than the first full month of the pandemic. So the pandemic arrived in March of 2020. In April of 2020, we incurred a $12 million loss because we completely shut down elective surgeries. Patients were afraid to come to the ED, afraid to come to the hospital. We were still at full staffing, and yet our revenue had just plummeted. So you look at what we experienced just in the first 3 months of the fiscal year. That was a $28 million loss. It was in August and September that we really started developing what we call our back in black financial road to recovery. And no, it's not a off-take of the AC/DC Back in Black song. I know certain people have purported that that's what we were using, but I would imagine many of you have heard the finance or accounting term, operating in the black or operating in the red. So we've been operating in the red throughout the course of the pandemic. Our efforts are to get back into the black. So that's where it comes from. So we've implemented a lot of different initiatives to enhance revenue, to cut expenses. It's not come without heartache, as we've had to close services and lay off employees, implement pay cuts for our leaders, made a decision that we may not fund a match of our employees' 401k plan for the 2022 calendar year. The board's going to kind of take a wait-and-see approach and look how we end up finishing this fiscal year. So it's been challenging. It's been difficult, but it's been paying dividends. I mean, implementing team-based care. I wouldn't say that's been wildly embraced, wildly popular. It's a big change for people, and while it may be much more prevalent in other hospitals and areas, that has not been the case here. So it's a big learning experience for a lot of our folks, but it's helped us, become less dependent on that very expensive contract labor. In fact, I meant to share with you that just in this fiscal year, so we talked about the number of travelers we're using is coming down, the rate we're paying is coming down, but just in the first 7 months of this fiscal year, July 1 to January 31st, we've already spent $36.1 million in contract labor. We have now spent $97 million in contract labor since the beginning of the pandemic. $97 million. And yet, we did not receive a single increase in Medicare reimbursement rates, Medi-Cal reimbursement rates, commercial insurance rates. All of that has been funded by us, which has come out of our cash reserves and unfortunately really depleted those cash reserves. But again, things are turning around. So we saw those significant losses in the first 3 months, but we had a loss in October, but it was lower. We had losses in November, and then I mentioned December and January, but the trend is going in the right way. In fact, Compare that, we lost 28 million in the first 3 months of the fiscal year. But since that time, over the last 4 months, we've lost 11.4 million. So 28 million in the first 3 months, 11.4 million in the last 4 months. Melinda Tupper, our CFO, just last night in our board meeting was presenting kind of her forecast, her outlook for the remainder of this year and the next fiscal year that will start on July 1. Conservatively speaking, if we are able to continue to sustain the initiatives that we've enacted, we believe that maybe by April, May, we might get to break even, actually even see a small black positive operating margin, and then sustaining those into the entire next fiscal year, actually to generate a positive operating margin next year. It's going to take us time to recover. And it was interesting, I was I think it was in our executive team meeting just before I came here, one of our executives was talking. She just had this was Carrie Noweski. A couple of her nurse leaders had just gone to a conference with a lot of other hospitals. And there were all these hospitals describing their current condition. And they sat there and they looked at each other and said, wow, you know, we have it so much better. I mean, these hospitals are in so much worse condition than we are, which, you know, we've been very open and transparent about, you know, the challenges here are severe, but we're not on the brink of bankruptcy. We're not on the brink of closure. We're not following in the footsteps of Madera Community Hospital or other hospitals. And we've demonstrated our ability to get back on our feet, to turn things around. There probably will be other hospitals that file bankruptcy, particularly the more independent, standalone hospitals that are not part of a health system, don't have the resources to draw on. But we're headed in the right direction. Sorry for the long answer, we're definitely trending in the right direction.
Yeah, that's good. And when Melinda gets excited, that's good too.
Yes.
Yeah.
When she talks about the goosebumps on her arms, right? That's
must be a CFO thing.
I guess. Yeah.
Okay, so you've been very, very busy since fall.
Yes.
This group is well aware. You wrote the letter to the governor. We were by ourselves. You were the lone CEO that stepped out and really, I'm going to say, you took the lead on something that other hospitals were experiencing, but nobody was really brave enough to stick themselves out there and really talk about it. You did. And so you've been doing a lot of things since then. So why don't you give us an update on your advocacy efforts from this point?
Thank you. I will tell you, I didn't think it was bravery at the time. I felt like it was the responsible thing to do. Initially, I reached out to our community. The last thing I wanted to happen was for you to see us laying off, hundreds of employees and closing services, and you were hearing things, what's going on at Kaweah. So I made a decision very early on. I got back from my 2-month sabbatical on September 1st. I got to come, see what had happened in July and August, and then get to experience what happened in September. So I went on the local roadshow, and I met with a lot of different service groups. I'm meeting at 6:30 a.m. tomorrow with the Breakfast Lions Club, but I met with most all the Rotary clubs, most of our community advisory committees and ambassador groups, and so I wanted you to hear it first. I then wrote a letter to the governor and many of the state legislators, many of our congressional legislators. I wanted them to know firsthand what we were experiencing. I was pleading on behalf of all California hospitals for funding, similar to what the federal government did under the CARES Act and established a provider relief fund. We were not fully relieved yet. We needed additional support, and we had got nothing from the state. So all the support we got came from the federal government. And I guess I was probably, not incited, is that the right word, but I was motivated after, frequently listening to the governor brag about the $100 million budget surplus that the state generated in fiscal 22. And it deeply bothered me that California hospitals were suffering so deeply, and that we were just really being ignored. So that caused me to write that letter. I frankly thought that every CEO in California, hospital CEO, would be jumping onto that bandwagon. But like you said, I learned that in some respects I was the lone voice, and I didn't understand that. I do understand it now, and I appreciate probably their hesitation, because I similarly am concerned that my transparency has caused, understandably, a tremendous amount of anxiety in our community and in our organization. That's not what my intention was. My intention was, to bring attention, to bring knowledge and understanding. But that can cause your employees to fear losing their job, and maybe I need to go look someplace else. Or a community member to be afraid, apprehensive about coming to the hospital, because if they're having such struggles, maybe they're going to cut corners. Maybe they're going to try to discharge me sooner than I'm ready to go home. Maybe I'm going to get cheap drugs or cheap supplies, and that's the furthest from the truth in terms of, in fact, throughout this whole pandemic, Kaweah continues to be award-winning. Going from being one of the best 250 hospitals in the nation to now being one of the best 100. Top 50 cardiac surgery programs, number 2 in the state. Some of the lowest hospital-acquired infection rates and treatment of sepsis and so forth. So we definitely have not short-shrifted any of our patients. We continue to provide high quality, very safe care. But these other CEOs were concerned about that. So it wasn't out of bravery, it just seemed like it was the right thing to do. But it did throw me into the spotlight. And so I've joined Carmela Coyle, who's the president of the California Hospital Association, represents about 400 hospitals up and down the state. So she and I together, we spent one morning meeting with about 60 of the California congressional delegation, the legislators and their staff. And Carmela kind of gave a state of the California hospital industry, and then turned it over to me, where I told our story about what our hospital is experiencing and what our needs are. The following week, we did that with about 100 state legislators and their office staff. The day before that virtual meeting with them, I went down to Los Angeles, and I was joined by 3 other California hospital CEOs and Carmela and some of our staff. And we met with the governor's Secretary of Health and Human Services, Dr. Mark Galley, who basically oversees the Medicaid program and the California Department of Public Health. And we had the opportunity to spend about an hour and a half with him, again, sharing our stories. And they were all very similar, all 4 of us hospital CEOs, and they were from the North, Central, and South, all had a very dire story to share. Carmela is taking other California CEOs elsewhere in the state and arranging similar meetings with the Secretary Galley to share their stories. I was just contacted again yesterday by Carmela Coyle asking me if I would speak to a healthcare economist here in the state. He's a USC professor, but apparently very involved in policy setting or influencing healthcare policy in California, and he wants to be able to speak with me. He doesn't necessarily have a very favorable opinion of hospitals. He hasn't always been the most friendly, and I think he's has a lot of skepticism about whether what we're talking about is the truth or not. So I look forward to speaking with him. Next week, on February 28th, I will be presenting to the Tulare County Board of Supervisors. They've invited me to come share, our situation with them, as well as talk about possible solutions. We've made a $1.5 billion ask of the governor. We've asked him to put a line item one time in the fiscal year 24 budget, a financial lifeline to hospitals that would give us the ability to get back on our feet. It would be distributed in direct correlation to your financial condition, but probably more importantly, the size of the Medi-Cal population that you are taking care of. Because that's really what is having the biggest impact. It's clearly what drove Madera to closure. They're experiencing the same high cost of labor, high inflation with drugs and supplies and energy and so forth. But California pays some of the lowest Medicaid rates, if not the lowest in the entire country. And part of my story with my advocacy story is that while Tulare County has the highest number of Medi-Cal enrollees of any of the 58 counties in the state, more than 60% of Tulare County residents are living at or barely above, or probably many below the federal poverty level, and so they're covered by Medi-Cal. At the same time, we haven't received an increase in our Medi-Cal inpatient reimbursement rates for 14 years and our outpatient reimbursement rates for 30 years. And yet healthcare inflation has gone up 187% over that same 30-year period. So we literally, every single Medi-Cal patient we take care of, we lose money. If our outpatient Medi-Cal services were just paid at Medicare reimbursement rates, that would be a $30 million annual increase to us. And so that's the second part of our plea to the governor and the legislature, is you have got to reform Medi-Cal funding. Hospitals will continue to close if you don't do something about it. And the governor and the legislature are, very proud of the fact that they now have extended Medi-Cal to every single California resident, including the millions of undocumented immigrants that live in California. Very committed to health equity. And I agree. I agree that every single resident in the state of California, here in our community, deserves access to high quality, safe care. It is not fair that because I have insurance that I can get my shoulder repaired, my torn rotator cuff, but because I'm poor and I'm on Medi-Cal that I can't. But that's the reality, because, when we were profitable, we could afford to provide that shoulder repair to that Medi-Cal patient at a significant loss, as could other California hospitals. But we can't anymore. We have lost so much money over the course of the pandemic that we can no longer afford to cover the cost of the state's Medi-Cal program. And you can't demand health equity and then not provide financial equity. Right. And it's really is the state's responsibility to fund doctors and hospitals so they can cover their costs to stay in business and to continue to provide this care.
I'm enjoying watching all of this advocacy, and I'm going to still call it brave, because to me, if you step out in front of the pack and lead the way, I think that puts you out ahead, and that's bravery. So thank you. Thank you for your transparency. You made a commitment to transparency 5 years ago? How long have you been CEO?
Yeah.
5 years ago?
I think it was 20 years ago. something
Okay,
like this.
okay, well.
Maybe it just feels that way, huh?
Yeah.
Yeah.
And so thank you guys all for joining us. And if you have any questions, feel free to email us after this. And Gary is always available to answer questions that we have. And you want to end it?
Yeah, just, again, thank you again for tuning in, whether you're tuning in live with us or maybe watching this later with a recorded broadcast. But again, I am so grateful for your continuing commitment. You stayed with us. It's been more than 5 years since we launched our community engagement initiative, and so I'm so again grateful and appreciative that all of you have committed to that and are willing to be out there and answering questions from our community and asking us the tough questions and wanting to stay well informed. So thank you for that, and I wish you all a great day. Looks like we might get a lot of rain between now and Sunday, so that's a really good thing. So hope you all have a great weekend. We'll see you next month.